Gastritis in the word itself means inflammation of the stomach. And the main culprit of inflammation in the stomach or gastritis is the H. pylori bacteria. H. pylori can be undetected for quite some time before a patient becomes ill enough to get seen by a physician. It makes high acid production in the stomach, and that can lead to severe gastritis, which can lead to ulcer formations, which is the main reason people seek help, and then at the end stage, cancer. So gastritis is the main cause of that is H. pylori, the Helicobacter pylori bacteria. Signs and symptoms are the same with bacterial or viral infection of gastritis. And the main symptom is epigastric pain. Epigastric pain is right below the sternum area. The CBCs will show anemia, gastroscopy. The anemia is mainly going to be from bleeding ulcers of slow bleed where the patient loses blood over a long period of time. They'll need to do a gastroscopy or an EGD. An occult stool test to check for blood. Remember I said that mainly the reasons people come to get seen about is because they've developed ulcers and they have severe epigastric pain. By the time they have severe epigastric pain, then they have the ulcer formation going on. They'll get an H. pylori test. Remember we can test H. pylori in blood, stool, mucosa, blood work, or the breath test. We'll do a diet restriction, and that is the same thing for GERD, is avoiding foods that upset the stomach. So you want to avoid citrus, peppermint, coffee, things that are acidic. Spicy foods, stay away from that stuff. IV fluids may be given. Medications are antiemetics for any nausea or vomiting because they keep me ill. Antibiotics to treat H. pylori or other bacterial infections that might be going on. And the endoscopy is probably what they're going to get anyways. Nursing management will be to manage the pain, education on diet modifications, education on prescribed medications like PPIs would be the medications that they will get, Protonix, pantoprazole, Prevacid, Prilosec. Those are the drugs that they'll be given for this disease. Vomitus or stool color in the description. So we're looking for any signs of bleeding. So your vomitus, you're looking for coffee ground emesis or maroon or melena color vomitus. Melena in the stool, and the vomitus would be the coffee ground color or dark black color. Peptic ulcer disease education. So that would be your diet modification. Avoiding alcohol, avoiding smoking, taking your antacids like you should, your PPIs like you should, because gastritis in itself will inflame the stomach and create ulcers. Okay, so H. pylori infection is the main cause. There may be a family history of peptic ulcer disease. Some people are just more susceptible, have more acidic stomachs. Chronic gastric inflammation will lead to gastritis and then lead to peptic ulcer disease. So we've kind of moved on from the gastritis and then more severe form of the peptic ulcers forming, so peptic ulcer disease or PUD. Patient complains of epigastric pain that does not radiate, so it's right there in the center. Eating actually relieves the pain. And if there's back pain, that suggests some pancreas irritation. So maybe the ulcer is on the side of the stomach that's inflamed, and then that inflammation is swelling and it's rubbing on the pancreas and making the pancreas hurt. Will have bleeding, so hematemesis is vomiting blood, or melena, that's stool with blood in it. We will look for that with a hemoccult test or a smear to the lab. And sometimes black tarry stools is related to peptic ulcer disease, and that's indication of blood. The patient will get an upper GI series done, so they may have that barium swallow done where you can swallow the barium and then see if there's ulcer formations in the stomach. An EGD is the main route that they will go, and just take a look with a scope. They may have a low hemoglobin from blood loss and low red blood cells from the blood loss. The main treatment is eradication therapy, and that means we want to get rid of the source of the problem. If it's H. pylori, we want to get rid of that. We want to get rid of the ulcers completely. Some people may have an ulcer that is so big that it can obstruct an obstruction of pylorus, and then they may bleed so much that they may need some resuscitation. The resuscitation here is talking about resuscitation of the fluid imbalance, not exactly CPR. So we're going to resuscitate the patient, and that means we're going to give blood products and we're going to give IV fluid. So that is what this word means here in this context. If the ulcer is so bad that it's bleeding so much, or it's so big that they might have to take part of the stomach out and do a gastrectomy. So they may have to surgically remove part of the stomach. With a gastrectomy comes a high risk for dumping syndrome, or they can have this if they don't follow the discharge instructions completely. So we'll talk about that in the next slide. Nursing management will talk to the patient about how their food relates to their pain. So we would expect that when they eat, they feel better, because when you're eating, you're kind of soothing, covering that ulcer, and it doesn't hurt as much. Vital signs will be taken to watch for signs of hypovolemia, surgery or procedure, then diet modifications, and then the nursing management would be the medications, just like in GERD. Okay, so here is dumping syndrome. We must watch for this after any sort of gastric or bariatric surgery. I'm not sure why the slide is so big right now, but anyway, so a gastric or a bariatric surgery where they're going to remove part of the stomach, whether it's for weight loss or for an ulcer or for whatever other reason, it's still the same for post-care, okay? Dumping syndrome happens 15 to 30 minutes after eating and up to 3 hours later. What happens here? We have the duodenum, right? We said the duodenum receives signals. It sends to the pancreas and the liver, and it says, hey, we need digestive juices to get rid of some of this fat, digestion, calcium, carbs, and this. Okay, so when the patient eats, so now they have this surgery, and they remove part of the stomach. So they've removed the stomach here. So now they just have this itty bitty pouch. It only holds a couple tablespoons of food. And they've rerouted the enzymes here. So they've rerouted the ducts. And now they come in this way. Okay? So everything's kind of been rerouted here. But what happens is this pouch is not very big. It's really small. So when you have too much carbohydrates, or when you have carbohydrates, the ducts think, the enzymes think, hey, wow, I do not know what to do with all these carbs you just ate, so I'm going to flood the symptom. I'm going to flood the body with insulin, because we know the pancreas produces insulin. So here comes insulin, a lot of insulin, because it sees that there's carbs here, because the carbs did not have time to digest, so they went into the jejunum here undigested all the way, because there's not enough space here to digest it, so it gets dumped. So it dumps. When it dumps undigested carbs, you know, digestion starts in the mouth with digesting carbohydrates, and then the further digests in the stomach when it sits there for a few hours. Well, now your stomach's as big as your thumb, and your stomach just dumps it. it tells the pancreas that, hey, time for some action, secretes a lot of insulin based off of this undigested food here, and that creates havoc on the body. So now we have concentrated food that leaves the stomach too fast. It causes fluid to enter the intestines or the gut from circulation. So it's going to pull in fluid. So the way the body tries to handle too much of something is to flood it. So it's going to pull in water. So water is going to flood. It's going to pull in. Water's pulling in from the circulation. So if we're taking water out of the tissues, all the water in your body, or a lot of the water in your body is going into here, then we have nothing out here. Nothing anywhere else in your cardiovascular system. So that causes hypovolemia, which causes syncope, because you just had a huge dip in your body volume all of a sudden. And that causes your low blood pressure, and it causes low blood sugar because of all the insulin that was secreted. So hypoglycemia, dizziness, sweating, palpitations, and cramps, or diaphoresis for sweating, because it is like an insulin reaction. So diaphoresis, sweating, palpitation, and cramps, because oh my goodness, this abdominal stuff is going to be it's going to cause cramps. All this stuff going on here, cramping. So high carbs causes the pancreas to secrete insulin, causing hypoglycemia. Okay, so we don't want to have dumping syndrome, where our intestines is tricked into thinking that they ate a large meal and that they need a lot of insulin. So it happens 15 to 30 minutes after eating and up to 3 hours after. So what are we going to do about it? How can we stop this from happening? So believe it or not, so what we want the patient to do is to lay down after they eat. Yep, it's backwards from GERD. GERD said sit up for 2 hours after you eat. For dumping syndrome, after a gastrectomy, lay down for 2 hours after you eat to help prevent dumping syndrome. This is just another mnemonic picture that shows how the dump truck here has the carbs and high carbs here, and it goes into the duodenum or jejunum, whatever is left, and then you have all the water that's going to start shooting in here, and it's going to fill it up, causing hypovolemia, low blood pressure. The pancreas secretes insulin, that's going to cause low blood sugar, and then you got the symptoms of hypoglycemia too. And then dizziness with that. So how can we prevent dumping syndrome? We will tell the client to eat small, frequent meals, which will help delay digestion. Do not drink with your meals, so no fluids with meals. We want which helps to delay the emptying of the stomach, so don't eat and drink at the same time. Lay down after the meals to delay the emptying. We will have you start to experience dizziness, you need to go lay down, bed rest, or if any other symptoms occur. So try to slow down the gastric emptying as soon as possible. Make sure they understand the importance of small meals. So a patient who has had a gastrectomy for weight loss is at risk for gaining all that weight back if they do not understand that they need to still continue to eat small meals. Okay, so the stomach can stretch out over time, so they need to understand the discharge instructions. They have to understand also that they can't eat large meals like they did before their gastrectomy because of the dumping syndrome risk. Next is about stomach cancer. You'll see that the things about cancer for every system are basically a lot similar. So here you see a stomach cancer, and here you can see it's bleeding. Cancer just gets swollen. It's swollen with fluid. It's cancerous cells, and then it also creates ulcers and it's bleeding. Okay, this is the stomach. This may be the opening to the pylorus here. So we're just going to look for the stool that contains blood. They may have a barium CT scan, maybe a barium enema. They'll get a colonoscopy. I'm sorry, not a colonoscopy, but a barium swallow. CT scan, biopsy, gastric analysis. We're looking for H. pylori culprit. They may get the subtotal or total gastrectomy, chemotherapy, and palliative radiation. So they may also get a PEG tube, depending on, or tracheostomy tube, depending on what kind of spread of cancer they have. So for stomach cancer or nursing management, patients who have had a vagotomy need teaching that this decreases the acid production in the stomach, increasing their risk of cancer. So a vagotomy is a cut of the vagal nerve that goes to the stomach. Okay, so people have a vagotomy done as an alternative treatment option for GERD and reflux. So, or chronic gastritis. If we can decrease the acidic production in the stomach, they'll feel better. Okay, but that comes with the risk that now you don't have a lot of acid in your stomach, and it leaves no acidity to kill things in the stomach, and it increases the risk of cancer. Well, of course, we'll remind them about dumping syndrome in small meals too. Okay, NCLEX question. A nursing intervention for someone with a gastric outlet obstruction includes this. Now, I didn't necessarily talk about gastric outlet obstruction, but that means gastric outlet is the pyloric sphincter, and obstruction is something that blocks it. So basically, something that blocks it could be a really big swollen ulcer or cancer, either one, something that blocks the obstruction. Okay, so nothing's leaving the stomach. Okay, so what should we do? Give Tylenol, feed them small meals, give them an NG tube for suction, or give them fluids. Okay, so you have two things that are similar, feed and feed. Okay, do we want to feed someone whose stomach does not have an outlet? No. Okay, so the correct answer is 3. Provide an NG tube to continuous suction. Okay, and usually that'll be on low intermittent suction. But our stomach is still producing juices, and it has nowhere to go, so they will be nauseous. And providing the NG tube will help with nausea, and it gives somewhere for the juices to go. So that concludes the gastritis and PUD section.